Good evening, everyone. Welcome to our webinar for endometriosis. It's the first from Cromwell Hospital. Endometriosis is a condition poorly understood that affects millions of women worldwide. And today will be a panel of experts to talk about endometriosis in detail. My name is Amer Raza. I'm a consultant gynecologist and endometriosis lead consultant in Cromwell Hospital. I'm a robotic endometriosis surgeon, and I do my research in endometriosis in Chelsea and Westminster Hospital. We are incredibly fortunate today to have a panel of distinguished experts in the field of endometriosis. These specialists have dedicated their career in gynecology, women's health, and are specifically helping patients with endometriosis. I will introduce them from my right side, Mr. Valerio Celentano. Mr. Valerio Celentano is a colorectal specialist with a special expertise in inflammatory bowel disease, which is a very complex part of colorectal care. But he developed interest in endometriosis many years ago, and now he's one of the finest consultants when it comes to bowel endometriosis. We have been working together for many years, and it's absolutely a pleasure to have him here on board. Thank you. Thank you. My other side, right side, is Maya Al-Mimar. Maya Al-Mimar is a consultant gynecologist and lead consultant for adolescent gynecology in Imperial College London. Adolescent gynecology or endometriosis in young people is a very challenging issue. And we are very fortunate to have Maya here, who is not only a gynecologist and expert in adolescent gynecology and endometriosis, but also a fine ultrasound scan expert who has done higher degrees in scanning and diagnostic capabilities. We have on the left side, Denia. And Denia is our clinical nurse specialist who is, if you look at the endometriosis care, it's like lots of people, and Denia sits right in the middle of it to arrange and organize everything. So her role is absolutely pivotal in any complex endometriosis care. So we're very fortunate to have her here and join us in this panel. Then we have Mr. Pavlos Pavlaki. Mr. Pavlos is sitting somewhere in the sunshine in Greece, and very fortunate for him to join us now. Pavlos is an accomplished robotic surgeon in urology. He has done his robotic master's and expertise and PhD from Sweden and Paris, and now he's managing complex urology problems such as bladder cancers and ureteric abnormalities in robotic surgery. And we are fortunate to have him on our endometriosis team because, as we all know, that how endometriosis can have an impact on ureters, bladders, and kidneys. So having an expert like him on board makes this very complex disease manageable. Thank you. And we also have with us Herod with us, who is sitting in the background, making sure that all the technology works well. So at times we may have to ask her to come and help us. So we will start our discussion now. The way we will do it now, that I will start talking about endometriosis and the challenges we all face. I'm sure many of you sitting here will be either patients or one of your loved ones will have this problem, or you will be interested in this disease. I'll be going through some fundamentals of endometriosis, and then we'll ask my all colleagues with expertise about relevance of endometriosis in their subspecialty, and then we'll come back to question and answer. We've already received many questions, and I'll try to answer all the questions. However, if time didn't allow us, then Denia has promised me that she will be answering all the questions, and they will be on the website as well for you to see. Endometriosis, the simplest definition I can do is a tissue resembling the lining of the womb, growing outside the womb, attaching itself to the other pelvic and abdominal organs, causing inflammation, scarring, and cysts. This is the simplest way we can define this problem. It's the most common disease, but you have never heard of. At least 1 in 10 women suffers with pelvic pain and this problem. And if we look at the total number in the world, it will be 250 million and possibly more if we take the higher number of the endometriosis people in prevalence, about 500 million. There's no diagnostic test for this disease, which is so common. We do not have any cure if we diagnose someone with endometriosis. It affects from simple quality of life issue to very severe problem in fertility. And not only this, it is not a disease which is affecting one organ or one thing. It goes on to impact on so many different organs in the body. And again, from superficial to deep disease, it has huge implication for our body. If we continue with this challenge we have, we all know, and I'm sure many of you would have read it, there's a delayed diagnosis of 7 to 9 years, even if one has been going to their GPs and specialists. Infertility is affecting over 20% of the people. And in spite of all the challenges, we have lack of awareness and lack of research, even though this problem is so common. So if I take all these things in this one few words to summarize them, it's like etiological confusion. We do not know where this disease is coming from, and then how to treat it, therapeutic anarchy. So we really feel ourselves sometimes lost that what's the right way should be. Now, I'm not going to take you through all the slides. There's a lot of different slides, but just give you a taster. There's so many reasons, so many causes that why endometriosis can start. There's not one simple mechanism by which I can say this is the cause of that endometriosis. There are many theories, and these can explain endometriosis in different ways. Either it's a theory where cells can go outside the uterine cavity and adhere, or it could be an estrogen dominance, or it could be at cellular level. We may have infiltration, proliferation of cells due to increased natural killer cells leading to tissue injury and repair and fibrosis. Or we can talk about other inflammatory cells, genomic alterations, epigenetic theory. I can keep going with different fundamental immunological and inflammatory response to the body, that how it keeps on growing from one tissue to another tissue, jumping from one organ to another organ, creating a huge problem and indeed causing massive issues. Even immune regulation that can become abnormal in this disease and lead to endometriotic lesion. And all these different way of explaining things, etiologies, then takes us to how patients present to us. And if I put it in a simpler word, it's a symptomatic storm. Yes, it could be a very mild pain at one end of the spectrum, but the other end is a pelvic pain, excessive cramps, is pain with bladder, urination pain, bowel issues, constipation, nausea, abnormal heavy menstrual flow. Fertility becomes a huge issue in about 15 to 20% of patients because it's a disease in young people. Mostly people will come to us between 20 and 40, even though it can happen at any age, which Maya will tell us about a young age, and even we see people at the older age as well. Pain during intercourse, vaginal bleeding, fatigue. So in brief, it involves so many different organs of the body causing problem. And if we look at the etiology, and that's where the challenge comes from, given that it involves so many organs, gastrointestinal, gynecological, urological, musculoskeletal, even psychological, but sometimes we forget that when someone is suffering with so many problems, it becomes a huge stress and anxiety, and even makes it difficult to cope in everyday situation. So this disease is not a simple gynecological thing. It's far more than that and far more complex. And the challenge comes obviously for GPs and doctors, how to identify that one patient who is suffering with this problem. And that's, I think, where this webinar comes as well. Management of complex endometriosis. It is not one person can do everything or one expert knows how to manage it. Absolutely not. Because disease is affecting so many organs, it has to be multiple experts come in one room and talk about every individual patient and come up with a plan. Gynecologists, bowel specialists, urology surgeons, radiology were expert in finding the endometriotic lesion in MRI scans or ultrasound scans, chronic pain team, physiotherapists, psychotherapists, nutritionists, dietitian. It all has to come together to manage this disease. I mean, in this room, you see 4 of us sitting here and Pavlos on the line, but actually we cannot even put people in one room. There's so many of them involved in care of one patient. but I believe this is just the start of our webinars, and I'm sure we'll bring in more experts as well who are very key to the management of endometriosis. Given these challenges of diagnosis and the treatment, there's a huge amount of research. I don't want to give an impression that it's all doomsday scenario. Absolutely not. Many things are happening now, which are research is moving forward to see how endometriosis starts and how it can be treated. Scotland, Leicester, many of the big research centers in Chelsea and Westminster Hospital, there are many research projects now going on, which are almost getting to some kind of conclusion as well that what's causing the problem. Even just giving you a brief view that how different research projects are running, Regal study, Diamond study, and the studies now, and the SAFE study for endometriomas is coming, which are helping us with all this problem. So the work is still going on. As we move this discussion further and come up with your question, we'll come back to surgery, treatment, various treatment options, the new advances in the endometriosis treatment. I will now present a case actually of a difficult endometriosis, and then while all the colleagues are here, like any multidisciplinary meeting we do here very frequently to see how every expert will tackle the disease. So I have a patient here who is a 36-year-old presented with severe pelvic pain, period pains, and she also has a right-sided loin pain. She had an ultrasound scan which showed there's a 5-centimeter endometrioma. Mobility sign was negative, which means that all the pelvic structure along with ovaries were frozen together. She went on to have MRI of the pelvis, which showed she has a rectovaginal nodule, about 4 centimeters in size, which is also invading the muscularis of the bowel. And I will make these things simpler as we go along. She also found to have a right-sided hydronephrosis. So this is the MRI scan. This patient had blood tests for her fertility, and her AMH has come back 9.2 at the age of 36. AMH, as many of you know, or you don't know, is anti-Mullerian hormone. This is one of the most sensitive tests we use to check the quality of the follicles or patients' ovarian response to different hormonal treatments. It is a test which is used very commonly. So if we have this patient now, the question is how we are going to manage this patient. So I think I will take a start from the gynecological end, and then I will move towards Valerio and then going to Pavlos now. She's 36-year-old. She has been suffering with pelvic pain, and obviously now MRI scan shows severely deep infiltrating endometriosis involving multiple organs. There are two things in this patient. One is her symptoms and quality of life. And while we're looking at those symptoms and quality of life, second thing we always have to think about fertility as well. These two things go hand in hand. If I have to underline the principles of endometriosis surgery, that principle will be do as little as possible to remove as much disease as possible. So not to do too much, but to do little, but to remove the disease to help with the symptom. It's a little bit different from cancer operations, where you want to remove as much as possible, not to leave anything behind. So endometriosis ethos, our philosophy is different. Second thing is, no matter what I do, I have to make sure that the functionality of any organ does not get an adverse impact. It means ovaries function normal as they are, the fallopian tubes are left intact, the bowel functional, and the bladder fine, and the uterus is fine. So no functional impairment should happen to any of the organ as a result of that surgery. And needless to say, and many of you who are now at the forum as well, endometriosis is a disease of young people. And really in young age, all the way from starting from very young age, all the way to 40 and 45 people, it's a disease you want to be very careful when making these judgments, that how it will impact on the quality of life, whatever decision you make, and how the fertility. So in my case, in this patient now, one, she is having severe symptoms. So I need to think about giving her the option of conservative, medical, and surgical. That's just a routine practice and the right practice to open all the options to patient. And then when it comes to medical treatments, our hands are very limited. There's no one magical solution or tablet I can give it that will help you. We know when we give medical hormonal treatment, which can range from combined contraceptive pill to progesterone, only tablets to Dynagest, and moving on to injection Zoladex and generic analog injection or agonist. These treatments have limited value. They help with the symptoms. And we know that then 50% of the cases, even if we are taking medical treatment, it helps improve the system, the disease still may keep on growing. So all these pros and cons of medical treatment needs to be explored when I'm going for a medical treatment or a surgical treatment. When it comes to surgical treatment, then obviously the most common approach will be laparoscopy, a keyhole approach, and excise the disease. This word, I'm sure a lot of you hear very often, is it an excision, is it an ablation? Now in my practice, and if you look at all worldwide practice in major endometriosis center, the excisional technique, when we remove the disease, is the right way forward. It's like tip of the iceberg. If I see a black lesion in the peritoneum and go and burn it, yes, we have burnt it, but the root of it, the iceberg underneath, can be much deeper. So excisional surgery allows us to remove all the abnormal tissue. But again, this excisional surgery then needs to be balanced with functionality of the organ, not causing any harm. And that's the important parameter. So in this case, I think as a gynecologist and endometriosis specialist, next thing will be to proceed to multidisciplinary meeting, which we are doing now, and it will be after discussing all the options with the patient to proceed with surgery. And if I'm proceeding with surgery, Valerio, she has bowel symptoms and muscularis is involved as well. So how will you counsel this patient, and what are the important things you will be taking care of while you're planning to operate on her?
Yes, for sure. I mean, this is a procedure where multiple specialists like the urologist, the gynecologist, the colorectal surgeon will need to be involved. From the perspective of the colorectal surgeon, we've heard that there is a quite sizable nodule on the bowel. It's 4 centimeters, very likely is causing a lot of symptoms due to pressure, has a risk over time to get bigger and cause even very extreme problems like bowel blockages or causing pain and bleeding during periods. So if surgery is the way forward, during the operation with robotic surgery, we will repeat the assessment that the MRI scan has made, essentially where the nodule is, how large it is, and how deeply, which is very important, how deeply inside the bowel wall is going. In this particular case, the scan is suggesting what we discussed earlier, which is having roots inside the bowel that we call in medical words muscularis involvement. So one of the deeper layers of the bowel wall has been affected, which means that during the operation, we will certainly attempt the shaving procedure, which is just peeling away the nodule without damaging the bowel. But there is a chance during this operation that we might not be able to remove completely the nodule with the shaving. And that's why when we counsel you in clinic, we will be discussing with you about a bit of a more of a next stage treatment, which is the bowel resection. So during the operation, if we can't remove it with shaving, we will need to remove a little piece of bowel during a bowel resection and joining the bowel together. Obviously, during the operation, when all this assessment happens, you will be sleeping under anesthetics, which means that we need to discuss with you all these different scenarios in a dedicated appointment in clinic, hopefully a few weeks before the surgery, so that you can have the time to process and ask you all the questions that you're worried about.
I think, practically speaking, as you know, that even though MRI scan gives us a good idea, but it can underestimate the disease, and at times it overestimates the disease. So sometimes discussions goes on even during the operation as well, that what should we do, keeping the principle that minimal is the best one.
Yeah, definitely. As we said earlier, obviously, if there is an opportunity to improve things and to remove the endometriosis with a very conservative surgery, that will always be our preference. We will never do a bowel resection when that can be avoided, because obviously on the potential implication of, what we said earlier, either having infection, risks of surgery, or also preserving the function of the bowel in the future, where we go to the toilet not to feel.
And would you, we talked about doing the sigmoidoscopy intraoperatively after a resection. Would you do that preoperatively?
So we will tend to stratify patients according to different risk factors. When we assess the patients having endometriosis symptoms and surgery for endometriosis, we found that doing a colonoscopy for all patients was first of all quite difficult for patients to tolerate because the endometriosis makes the bowel quite stuck to the abdominal wall and other organs. So it was a quite difficult test for patients to have. And also because of the young age group and the known disease, very rarely we will find something that will change the management of what we're doing. So, for example, if we have patients where we are worried about other family members having a history of either bowel cancer or condition like Crohn's disease or colitis, we will definitely do some tests like a colonoscopy prior to the surgery, or in patients who have significant problems with diarrhea, losing weight, and we're worried about bowel inflammation. Otherwise, we will prefer to leave the assessment of the bowel at the MRI scan, but also doing these endoscopic tests of the bowel in theatre during the surgery when you are under general anesthetics. So obviously we will bypass all the problems with pain and discomfort. So we will tend to have an individualized approach. Right.
I'm cautious of time, but I think we'll a little bit go over 8 o'clock, so don't worry about the time. Let me go to Pavlov. Pavlov, she has a right loin pain and also hydronephrosis on the right side. How would you like to approach it pre-operatively before the surgery? And then what will be your philosophy during surgery to manage this problem?
Thank you, Amir, for the question. So having pain and having right-sided hydronephrosis, it is clearly evident that there is a partial obstruction of the right urinary collecting system of kidney to the bladder. If this is neglected and if this proceeds and continues, it can obstruct fully and it can damage inevitably the kidney functionality, meaning that it can severely and massively affect the overall renal function. So having right-sided hydronephrosis, I would definitely suggest to do a CT urogram, firstly to clarify the anatomy of the ureter, the connection of the kidney to the bladder, understand where exactly there is a stenosis. I want to explain what stenosis is for those who don't understand. It's an obstruction, and this obstruction is created from extrinsic factors. It's from the endometriosis that has involved the external tissue of the tube of the ureter, pushing it inwards. After the cystoscopy, the CT urogram, then I will inspect the bladder intraoperatively when we start the joint procedure and have an inspection of the right-sided ureteral orifice, which is the exit of the tube. Insert ICG dye fluorescent contrast to inspect during operation intraoperatively all the anatomy of the distal end and the whole ureter, and safely create a dissecting plane in order to, as you initially said very wisely, just remove what's really necessary without damaging. Only if it is really severely progressed endometriosis, in extremely rare cases, tissue of ureter will be removed. But otherwise, as I initially said in my initial presentation, more than 98%, this right side hydronephrotic blocked kidney will immediately have a patency of the connection and it will come back to normality.
Thank you very much, very helpful. And I'll just add one more point, or maybe Maya, you want to add something. She had a 5 centimeter endometrioma as well.
Mm-hmm.
How do you think endometrioma should be managed in case, because fertility concerns could be there?
Well, this is a really complex one, isn't it? Because there are, what we're trying to do, the difficulty of removing an endometrium is they can be quite adherent. And therefore the risk is that we damage some of the underlying ovarian tissue. So there are, depending on the degree, you could deroof, you could perform a true cystectomy and remove it, but risk some damage to underlying tissue. And I guess there the question would be is, her symptoms, how bad, how stuck, the size, and also her fertility wishes. We haven't asked if she's had children, if she wishes children. And I guess I wanted to ask you a question about one thing is preoperative GnRH. Would you use preoperative, downregulate preoperatively in this situation? And also maybe what would you do afterwards if she wanted to have a child or if she didn't want to have a child?
You're absolutely right. It's a very difficult discussion and one of the most complex part of discussion. So number one, anybody who has a severely deep infiltrating endometriosis with endometrioma, I will always downregulate them. Now, downregulation could be GnRH analog, but we can all use Dynagest and other medical hormonal suppression as well. Number one. Number two, when it comes to endometrioma, we know it now. There's a huge body of evidence. If I do endometrioma excision or cyst stripping from the ovary, it will lead to lesser AMH and also lesser ovarian reserves or follicle in the ovary. So our approach now in the young women who want to conceive and fertility wishes need to be very conservative. So you may have heard, if you go to Google and see it now, alcohol sclerotherapy. I don't want to give a wrong impression because it is not being done in many hospitals. So I don't want everybody to go to their hospital and say that we want to have alcohol sclerotherapy. However, there's enough body of evidence now coming from Europe and other countries now that alcohol sclerotherapy does have a role, leads to minimal damage to the ovarian reserve and also reduces the risk of recurrence. But that is again back to that difficult discussion we need to have individualized with every patient. And what should we do? Thank you. Okay, so that's, I think, bring this case just a little bit of perspective for all of you as well. Now, all of you sent a number of questions, and I think we'll try to answer some of these questions and see how far we can get. Otherwise, Genia very kindly will answer all these questions, and these will be on our website as well for you to go through, because every question is an individual question, but it helps everyone. So should I start trying maybe earlier than I want to? It's a very generalized question. So anyone with endometriosis, I will say, yes, have a family earlier than later. You leave it, we know there's an age-related impact, but again, if you leave it longer with endometriosis, everything becomes harder. I was diagnosed with last April. I have growths on my bowel which they wouldn't remove as I would need a specialist. Can this make me going to the toilet more? Valeria, would you like to?
Yeah, what the endometriosis can do on the bowel is that basically from the outside, as we've seen from the previous presentation, is pushing on the bowel and making the waiting room when we have to go to the toilet, the rectum, feeling the need that you need to go to the toilet more frequently. So one of the symptoms that we see frequently in patients with endometriosis nearby the bowel is what we call changing bowel habit and going to the toilet more frequently. So yes.
Our next question will be, how much of an impact does endometriosis have on fertility? So kind of we've answered it. Endometriosis definitely has an impact. If you ask me numbers, 15% of women will present to us in the clinic with a subfertility or fertility issues in endometriosis and they won't have any pain. So yes, endometriosis does have an impact on fertility. Then you ask me, does operating or surgery helps with fertility? Then yes, there's a good evidence to show that excision of endometriosis helps with fertility, natural fertility. When it comes to IVF, the numbers don't show the benefit, and it shows that even if you leave the endometriosis and go ahead with the IVF, it does not make any difference to the outcomes. But in natural conception, yes.
So the next question, what are the different symptoms you get with adenomyosis and endometriosis? And I was wondering if I have adenomyosis. So in terms of symptoms, they can be very similar. Adenomyosis tends to cause very much painful periods. It's not a condition that causes the scarring that we see with endometriosis and kind of a chronic pelvic pain or bowel symptoms or urinary symptoms. It really is unique to having painful and heavy periods solely. But it is associated with endometriosis, so you can often see them together. So that's really important to know. And to know if you have it is really based on your history, so your symptoms, but also a good quality, high quality ultrasound scan or MRI is really very good at diagnosing adenomyosis.
Good. Is there a weight limit for excision surgery? There's no weight limit, but there's always a weight limit when it comes to operation. These are high-risk operations, and a full anesthetic pre-operative review needs to be carried out because there could be issues with intubation. So therefore, weight is an important issue which your surgeons will discuss with you depending on your own situation. Is it normal to pass blood clots and mucus?
If the question is vaginally, yes, you can have heavy periods. It's with endometriosis, but just in case the question is rectal bleeding. Maybe we could touch on that just in case.
Yeah, again, rectal bleeding is a quite common symptom. Obviously, in clinic, we will check you for other common reasons of rectal bleeding, which are problems of the back passage, like piles, hemorrhoids. And then if we are worried about missing any of the problems, we will do a camera test of the bowel, such as colonoscopy.
Thank you. Next question is, I was diagnosed when I was 18, suffered badly. I'm now 47. How likely is my daughter to suffer with this condition? She's 10 years old. So various studies of population show us actually that this can go in the family. So for example, twins, mom, sisters, aunts can have endometriosis if you join. I think given that you have this experience, and this experience will be very helpful for your daughter to support her. Not that necessarily she has to have endometriosis, and as already Maya said, not every pain automatically means it will be endometriosis. Anything else you want to add to that?
Yeah, so be reassured, because she may not, and she may be absolutely fine, and that's really, really important. And remember, periods initially for many, many, many young girls can be painful. It's where it persists and where things are really severe and impacting her. Given the family history, you can always get her assessed if you have any concerns. It can be hereditary, as Mr. Raza just said, we just answered.
Next question will be, I'm skipping some, we'll come back to some answers later on by writing them. What advice would you give to someone who's trying to get their diagnosis to have more chance of being taken seriously if I go private? No, this is a very, very good question, and thank you for asking this question. Look, go to websites like Endometriosis UK, Health Menstrual Project. There's a wonderful helpline. Before you go to see your GP or a specialist, if you're suffering with pelvic pain, please read those helplines. Write down your diary, write down your history. Do not think you will recall everything when you sit in front of a consultant in that maybe consultation, which could be rushed as well. Write down everything, number one. Number two, with our experience now, we are much better that by your good history, a good examination like biomanual vaginal examination, and a person who is expert in scanning to look for endometriosis, they can diagnose with endometriosis. So if you go along with these things in your clinic prepared, I'm sure that you can get the result. It does not make any difference. You go private or NHS. There are excellent people in all areas who will be able to help you. Why do doctors misdiagnose endometriosis as a severe period pains for years before diagnosing? How can you improve the diagnosis process for their other patients? You want to add something to it?
Yeah, I think it's a really, really good point, and such a cause of frustration for so many patients because they feel not heard, and that's really difficult. I think there's 2 points about that. The first is there's been such leaps and bounds made in terms of diagnostics. It's not perfect in terms of ultrasound, MRI, but we're getting better and better and better. So a good quality ultrasound is very, very good at diagnosing endometriosis. It will not tell you, and again, as I said, a normal scan with a very mobile uterus, even in the context of somebody who has very difficult periods, might not exclude little spots of endometriosis. But actually, the difficulty with little spots of endometriosis, and Mr. Raza is involved in a lot of that research, I'm doing that research at Mary's, is that the treatment, surgical treatment of very superficial mild disease, is that we're not sure how much of a difference that makes to somebody with horrible periods. And that's the challenge that we've got. The other problem, just one other point about how long it takes, is that we don't really know the natural history. Is the first problem horrible periods and over time endometriosis develops, or is it that from day one you had endometriosis? And that's a very difficult question to answer.
Exactly, that's the challenge we all have, that we don't know which one endometriosis will grow much faster and severe, and which it will always stay as a mild disease and the genetic variation. How is to get the pain, proper pain relief? Why do pain specialists downplay pain? Just think it's psychological and prevent it from coming back. Let me go back up. I think how to get proper. Pain is a very complex thing. I mean, it has to be, and that's why we are very fortunate to have a very good pain specialist on our team as well, because a difficult area. Pain is a perception of the pathology was inside, and then how the pain is being perception by the brain and by our neurological system is a complex phenomenon. But downplaying, absolutely not. I think the important thing is that pain needs to be understood, the causes need to be discussed in detail, and all steps will be taken to help with the pain. And pain, again, is one thing which then leads to stress, anxiety, depression, psychological, and it all comes down to creating the full support structure around a patient. So hopefully next time when we'll sit in this room, we'll sit with possibly pain specialists, psychologists, psychotherapists, and those people to come back to this question in much more detail as well. I think we'll take one more question, then we'll come in towards the conclusion as well. I had hysterectomy because of fibroids and endometriosis was also discovered. Having this op, does it prevent it from coming back? I mean, looks like you already had a hysterectomy done, but your ovaries possibly may have left. I don't know how old you are, so I'm afraid I will not be able to say much, but endometriosis is a chronic disease. It can come back. So again, it depends if your ovaries are left and if you're taking any treatment now. So it depends on various factors at this time now.